So within the UK, we're lucky enough to have centrally commissioned biomarker testing. We now have a national genomic medical service, and in England we have 7 commissioned central hubs which are genotyping for all of the licensed drugs that we have here in the UK, many of which are actually already commissioned. For example, we have access in the NHS to first-line tepotinib for patients with MET14 splice site mutations. We have access to second-line selpercatinib for patients with RET fusions. And in due course, once we have license for HER2-targeted therapies, I do hope that these become on the test directory. Despite having these genotyping, the implementation of genomics has been problematic because of quite significant time frames between time of sampling and receipt of result. However, we need to be really mindful that each individual area will have their own issues with sample routing from the initial pathology lab to the molecular lab back to the oncologist. And what we need to be mindful of is that NGS actually gives us the most comprehensive analysis. If we're limiting to single gene assays, we risk false negatives. A very good example being EGFR exon 20 insertions, where if we're using PCR-based assays, as some laboratories are, because they want to make the sampling quicker, these can miss up to 50% of eligible patients. And those patients would otherwise undergo treatment with chemo and immunotherapy, where we know immunotherapy is not really likely to have any meaningful effect other than the potential to cause significant adverse events. So getting it right first time is a big issue in lung cancer and diagnostics in general, but especially in genomics. Now, one of the ways that we can take forward molecular diagnostics and genomics in particular in lung cancer is through the implementation of ctDNA. We have a huge amount of pilot data from many centres, both within the UK and outside the UK, which has shown that ctDNA testing in parallel to tissue NGS is complementary. Indeed, our work here at the Marsden has demonstrated that using it in parallel to tissue NGS has demonstrated faster turnaround of the complete genomic results, resulting in much faster time to patients starting treatment, which is really important for our patients because they're waiting for those results before starting treatment, and it's really important for the NHS because there are 62-day wait time targets that need to be met, and it's absolutely important because we can get the patients on the right drugs for their individual type of treatment. There's a lot going on in the field of ctDNA. There's an England pilot implementation of the utility of ctDNA in parallel to acquiring tissue, which is being run by NHS England and the genomics unit, but is fundamentally being delivered in a number of hospitals in England by respiratory physicians. So it's really important that our respiratory physicians understand what power they have with the utility of ctDNA to speed up the time to treatment, which is of critical importance to all of us. If any of you are interested in knowing more about ctDNA, I'd encourage you to dial into our forthcoming webinar, which is co-hosted between BTOG and the Video Journal of Oncology, where we have the UK's experts around the table deep diving into all aspects of clinical interpretation and implementation of ctDNA. Do join us.